Good afternoon. Thank you very much for taking the time out of your schedules to join us for this recorded webinar today. My name is Iracema Leroi. I'm an Associate Professor of Geriatric Psychiatry at the Global Brain Health Institute in Dublin, and I'm one of the directors of the Dementia Academy, which aims to support the knowledge and practice of frontline clinicians. The COVID-19 pandemic is having a significant impact on all of us and how we are practicing medicine, particularly in the way we are supporting older people with dementia and their care partners. So in adapting to this new reality, many clinicians around the world are starting to work in virtual or remote clinics. However, there are several issues related to people, older people with multiple health concerns, particularly people living with dementia, that we need to consider. Thus, it can be very helpful to share the experience of clinicians working on the front line. And we strive to ensure that our information is accurate, practical, and meaningful. So today, to share some insights into how the medicine of the elderly clinic has adapted to the new reality of COVID-19 social distancing, we have Dr. David Robinson, a consultant geriatrician and director of the memory clinic at St. James's Hospital. And just to clarify that the views he will share will be those of himself as opposed to those of his organization. So David, in your outpatient clinic, which you'll be describing for us, your clinic serves many older people, some of whom have dementia, with or without other health conditions. Can you please give us a description of the range of patients you see generally and how your clinic has gone virtual?
So just to give some context, I suppose, for people who aren't familiar with the institution, I work at St. James's Hospital, which was founded several hundred years ago as a workhouse. It's the largest hospital in Ireland, affiliated with Trinity College, with over 1,000 beds and 4,000 staff. Founded in 1703 and occupied by the rebels in 1916, which technically is a war crime, but we don't talk about that much. Within St. James's Hospital is the Mercer's Institute for Successful Aging, which was opened in 2016 and conceived as a dedicated institute for inpatient and ambulatory care. So we have a transition ward, rehabilitation wards, and acute ward. And on the ground floor, we offer general medical outpatients, and then specialized outpatients, including falls and blackout, memory, bone health, and cardiovascular health or stroke. So the numbers are large. In our general medical clinics, I'd see about between 600 and 800 people a year, and there's 5 of us, so there's about 2,500 patients. Most of that work is around memory or dementia, certainly in my practice, because as director of the memory clinic, I think I get more memory diverted that way. In the memory clinic, we see between 600 and 700 patients a year. Many of those are new, about 250 new, and the remainder are returns. So that's the nature of the clinic. The memory clinic is a tertiary referral centre, so accepts referrals nationwide, and the general medicine for the elderly tends to be more local.
Thank you very much, David. That's fascinating, the history particularly. Now, thinking about the new and the future, can you please describe the process of how you moved from the old way of working to what we're calling the new way, the COVID-19 applied way?
Yeah, so like any unit, we had our own processes and electronic processes for tracking patients' appointments. So we had to clear all of that and record it and set up new systems of creating a division of labour, identifying the labour, creating a division of labour, tracking what we were doing, tracking the outcomes, and then feeding back to the general practitioners. We have an electronic patient record, which we adapted to outpatients because it's usually inpatient focused. Dr. Rory Nee took a lead in that. We were creative in that we had a lot of staff go off at the beginning with COVID-related illness or COVID contacts who are actually well, who are self-isolating or quarantined. So we set those people up for remote access at home to the electronic patient record. So they're able to phone patients at home from their own homes. Patients weren't given a time window, but they were warned that they would get a phone call from a doctor. And we just worked our way through it. We started off with return patients. So those are patients that were known to us already. We had some form of relationship with them. In all, we did over 600 interactions across all of those specialty clinics, although I have numbers mostly for the general medical clinics and also for the memory clinic. We have now also started to phone new patients that are waiting to be seen. for new appointments. And that's a little bit trickier because we don't know them, and it's just a form of pre-assessment or pre-triage, really. I think the important thing for us was that there was a division of labour, a record on the electronic patient record, and then an output to the GP in the form of a letter, so that there was communication there.
Thank you, David. That's very helpful. Can you please describe some of the challenges that you've had to overcome, particularly in relation to working with people who might have cognitive impairment?
Yes, there's quite a few challenges. It's difficult to get people on the phone. It requires multiple attempts. Because of hearing impairment or other sensory deficits, it's difficult sometimes to make yourself clear or heard, and also to get the information. In terms of cognitive assessment, we've also had the situation where you can hear prompting in the background from a relative, or there may be prompts in the room, such as a calendar, which kind of undermines the effectiveness of that. There is a fair amount of information you can glean, though, from a telephone call, whether there's care or stress, whether there's BPSD. A lot of this is based on collateral anyway, and we were able to respond depending on those assessments.
So David, can you please clarify? I understand that you are seeing people who already have a diagnosis and you're trying to assess whether they've progressed with their dementia, but what about the need to make a new diagnosis of dementia, particularly considering that time is moving on and initially many of these new appointments had been pushed to the sidelines?
Yes, given the numbers of patients, doing nothing wasn't an option for us. New referrals dried up for about a 6-week period, but they're starting to come in again. In terms of the phone calls, of course, a lot of our patients with MCI will have transitioned during that time. The Cork experience and the consensus generally is giving a diagnosis of dementia over the phone is not a good idea. Most of us would not do that. So we have a day hospital which we can use for urgent reviews or medical reviews. So I think the numbers are there. Of 321 attempted contacts in our general medical clinics, we got through to 277, and 24 of those had to be brought to our day hospital. So it was about almost, 9% had to be brought to our day hospital. A good portion of that was dementia, either transitions or BPSD. There was also issues around Parkinson's medications and assessments of Parkinson's disease that had to be addressed. And then lastly, there was a mixture of other conditions such as falls or delirium or other crises that had to be addressed. In terms of the memory clinic population specifically, the clinical nurse specialist rang the returns and made an assessment. A couple of those sounded like they may have transitioned, and we're going to schedule appointments for them in the weeks ahead. Others sounded stable, there was no stress or BPSD involved, and those people will be scheduled for routine appointments in the months ahead. Of the new patients, our registrar phoned those and made some form of assessment over the phone. We feel that neuropsychological assessment, other than perhaps a blind MOCA, which has its limitations, can't be done over the phone. Certainly our neuropsychologists looked into it and felt that they would rather bring patients in for assessment in a socially distanced manner. So for the 12 new assessments in the memory clinic, we're going to bring them all in for neuropsychological assessment. Given that we've taken an extensive history from those patients already, some of those patients may not need to see a doctor other than for an examination.
David, can you please outline what you think are some of the benefits or pitfalls for patients and their families with this type of working?
I think there is a definite benefit. The patients really appreciate the calls, and they're glad that they haven't fallen off the hospital's radar, and some form of plan can be put in, even if it's only a provisional plan, even if it's just setting things back a few months for a face-to-face meeting. In terms of pitfalls, the relationship is undermined, obviously. We do have the option of using video calls, but very few people have taken up on it. I've only done one video call myself. Barriers to that tend to be the technology, either on the patient's end or on our end, and that is certainly a pitfall. It's hard to think of other advantages. I mean, we have been able to intervene in crises, and there has been admission avoidance as a result as well. We've had to admit 2 people from the day hospital in terms of those urgent reviews, but we've definitely headed off a number of other problems. On the clinical front, cocooning is not without its consequences. When the restrictions were lifted here on cocooning older people, I had met 3 patients in the first few days who'd had adverse events within 15 minutes of leaving their homes. So one of the benefits to this way of working is that we're able to offer support advice, even physiotherapy classes are being set up via Zoom. So we're able to deliver some therapeutics via this method.
So David, sounds like that requires everyone to be very flexible and adaptable. And I'm just wondering what your thoughts are about how the staff have reacted and what the pitfalls and benefits for staff may be.
Well, overall, the staff have been amazing. I mean, the whole hospital has reorganized itself within about 2 weeks, and stuff that usually would take months to do took place in the course of afternoons, entire units moving around, and people offering to work from home when they're in self-isolation. In terms of the work, the benefits to the unit certainly are that we've been able to discharge a significant number of patients from our general medical clinics. We're able to keep the waiting lists ticking over and able to intervene when emergently necessary. In terms of pitfalls, the assessment is incomplete, obviously. There are various things that are discovered opportunistically on examination of older people: aortic stenosis, atrial fibrillation, orthostatic hypertension, Parkinsonism. You can't really make any of those assessments over the phone, so you don't know what you're missing. Those are the unknown unknowns that you worry about. Blood tests for new patients are a big problem as well, and they're not coming into the hospital to have their blood tests done. And obviously things like asymptomatic anemias are a risk. So some GPs are doing that. So there's been a lot more communication and toing and froing. It's quite difficult to track all the activity. We are doing that, and we'll probably write it up, but that's one of the pitfalls also. Ethically then, there's difficulty, particularly with a cognitively impaired person where the relative is probably the contact in order to set up the call. There's a danger that the relative is going to take center stage and not the person with dementia. And also ethically, delivering bad news over the phone to people that you may not have met is just not acceptable. So hence we use the in-person reviews for that. And we do that in a socially distanced manner. So people are provided with face masks and are staggered in the day hospital so that we don't have multiple people in the waiting room at once.
So David, just thinking about the small proportion of people who have to come in or whom you prefer to see face to face, even with protection, are people generally willing to do that? Because our initial experience is that patients and particularly older people wanted to stay as far away from the hospital as possible.
Yes, we haven't done any surveys or anything, but anecdotally, I think the mood has changed a little bit. People seem to be more willing to come to hospital. It depends on the problem. A lot of, as you know, memory moves slowly. A lot of people are prepared to sit on it and wait until this is passed. But more recently, I've been asking patients, would you be willing to come into the hospital? And they've said yes. So I think that has changed a bit.
One of the key concerns, of course, we have of people who are developing dementia is the issue of capacity to consent, particularly when asking for consent to talk to a third party, such as a family member. How have you been able to manage that in your remote clinic?
I think we're probably taking quite a paternalistic attitude and doing it in the patient's best interest. Where people can consent, we aim to speak to the patient first always and get the patient's permission. If a patient is very demented, that's just not possible. I suppose we're acting in the patient's best interest and making a possibly incorrect assumption that the relative also has the patient's best interest at heart. Certainly, the experience on the wards has been fraught, and there's a lot of people in crisis with PTSD. Social services are patchy and in some cases reluctant to go into homes. So we're seeing that on the clinical front end. In terms of phone calls, it's often a three-way communication. You speak to the relative, you speak to the patient, you speak to the patient, and the relative, then back to the patient. That's been my experience.
Thank you very much for that answer. I think that's an area of development that we all have to figure out as we progress along this route. I'm just going to pose a final question. Now, we've talked quite a bit about the impact of the lockdown on care partners and families of older people with dementia or those who have other health problems. What do you see as the role of the geriatric outpatient clinic or memory clinic in supporting care partners and families?
I think there's going to be a huge role. I think we're going to see a wave of mental health problems, a wave of frailty, we know about the isolation. And we've set up a virtual social prescribing project in order to link people into resources around exercise and social connection. And I think from a mental health point of view, we're going to see a spike from that point of view. I think in the future, We will continue to do this for as long as is necessary. We'd like to think of this as a stopgap measure. One of the advantages for new patients that I didn't reference already is that some patients don't need to come to clinic. By the time the referral gets onto our table and we phone the patient, the issue may have resolved itself. The patient may have identified that anxiety was actually the real problem and their memory isn't the main issue. I phoned 3 new patients last week awaiting assessment in my general medical clinic, and none of them needed to come. So there may be an advantage to that.
So David, thank you very much. This has been extremely insightful and helpful. So it sounds as if potentially in the future we're moving towards a bit of a hybrid model, whereas the best elements of this type of working will be retained, but still there's an extremely important role for the way we did things previously. Do you want to make any last comments before we close?
No, just I agree. I think a hybrid model is probably going to be part of the way we continue to work in the future. Other than that, no, I don't have anything to add. Thank you very much.
Thank you very much for taking the time out of your busy schedule on the front line to support our education here at the Dementia Academy. And this webinar is recorded and there'll be a transcript available. If there's any questions or concerns, please do let us know. Thank you very much for your time. Goodbye.